anxiety itself. But I think, again, in future studies, maybe this kind of alludes to needing to look a little bit further into like, what is the anxiety stemming from, and then addressing, you know, what that is coming from. Maybe it's different for patients, you know, depending on so many different things. But I think that'd be something interesting to look at further.
Thanks, Carol Levy, New York City, Mount Sinai. So to carry on exactly what you said, that was going to be my first question. There are many validated surveys in terms of technology adoption, fear of hypo, and fear of hyperglycemia, because I would almost wonder as well from this anxiety piece, at least on the adult side, we deal with a lot of adults who are terrified of hyperglycemia, running A1Cs in the 5s, that we all worry about. And AID systems can provide benefit, but I've got a handful of these people that are looking at a downward trending arrow at a blood sugar of 280, and they're panicked and taking in juice because they see a downward trending arrow. So there's a lot more here. I think this is a great baseline and a lot of ideas for future. Thank you for doing this.
Thank you.
Any other questions? Okay. Well, to keep us on time, we'll move to our next presenter. And I'm sorry if I mispronounce individuals' names, but our next presenter is Siham Accacha at NYU, who will be presenting on improving depression screening in patients with type 1 diabetes. Give you the microphone. Oh, sure. Okay.
Yes, you were right. No problem with my name. Is it here? No. So I'm going to start by telling you what the project is. Actually, we have been working on depression screening in our program since we joined the collaborative. And as you all know, depression is one of the risk factor for good control of diabetes. And that's why, you know, it was started. You know, we were not having a good grasp of it. At the beginning, we were using PHQ-2. Let's see, it's working now. Okay, very good, great. Yes, here we go. So we were using PHQ-2, but then after we decided that we are going to be doing this, the depression screening, we switched to PHQ-9 that is validated for monitoring the severity of depression, and it's a 27 question that scores. So the purpose was basically to start with a baseline of 0 to 75% by August 2023. We extended, actually, when we started, we were stopping sooner, but then with this project, with this presentation, we can end up looking to August 2023. And our team consisted of a multidisciplinary team of physicians, nurse educator, nurse practitioners, CDEs, as well as a social worker and medical assistant. And we ran multiple PDSA cycle with education, creating folder resources, making algorithm, EMR changes, and referral to healthcare providers. So as this is our workflow, we created that as patient was arriving, the MA would obtain basically the vitals. At the same time, will evaluate if the patient needed screening. Then the questionnaire was given to the patient if the patient needed. If the questionnaire showed, you know, if they didn't need it, then that was fine, to continue. And once the PHQ-9 was, you know, filled up, the questionnaire was filled up, the folder is given, the paper is given to the provider who look at it, does it, and if there is no positive finding, nothing to do otherwise. And also the suicidality is evaluated. If it's positive, we send directly to the ER. Which thank God never happened so far. And otherwise, based on the score, we were managing patient, repeating basically the questionnaire at the next visit, and or referring to our social worker that we have on site, or evaluating if the patient was seen already by a psychologist and sending it to the psychologist, and make sure that there is a follow-up as well. So let me show you our PD. The first one started January 2022. And at that time, so we were doing, as I said earlier, a PHQ-2, but not for a lot of patients. 55% of our population, when we look at it, we're having that. And then we switched from to PHQ-9. Then we realized that basically our provider were very concerned about doing that. What's going to happen actually if we find positive screening? And are we going to even be able in a short period of time, we have half an hour to see patients as a physician and 45 minutes as an educator, they have it, to address that if it's positive or not, and basically look at the data. So then, so I started that and I realized it's possible. It didn't take too much of my time and it was feasible. I was able to have the support, and we basically expanded to the rest of the group. We are 5 physicians that MDs and 2 nurse practitioners. We have 3 nurse educators. And so we expanded, the screening was done. We realized that the MA covering needed education because they were not giving the paperwork, basically. Even if the folder was there, they were not looking at the folder to give it to the patient. And then also, again, the staff, our physician might not be looking at it because maybe they were not buying into it. So, and there were concerns, again, about what are we going to do with these results. So we had our social worker holding a workshop for us, a provider, explaining what to do, how to talk to the patient, and create basically a tip sheet and resource binder that we put in every single exam room for a provider to reach out to interpret the result and what to do next. So actually August or July 2022, we can see that we had an improvement. We tried to document the data, get the data out of the system. That was another issue that we encountered. We realized that the system, we were entering it, but we could not recruit the data. So that took us a while to get that too. And we worked on, again, basically showing that making a patient take the PHQ-9 at the MA, making sure that the MA was entering the data in a right manner into the chart, and then making sure actually the patient, we realized that a large number of patients were actually screened by the end of that timeline. And as you can see here, is it working? No, oh, maybe it's this side. Okay, here. So you can see here that by June, we reached our goal. So we went above 75 percentile, but by July, we were happy. I guess everybody was slowing down. It was summer. Less attention was paid to the program. Then we continue our basically vouching. We have a diabetes meeting every month. And at the meeting, we realized we are going to be talking about, please, to everyone, to nurse practitioner, to educators, and our provider and fellows, to make sure that to check for patient, do they have the screening done or not? And we created basically a place in Epic. We have Epic that we put the score in the schedule showing the last score that the patient had, PHQ-9 score that the patient had. And so if you look at your schedule, patient has diabetes, you have to see a score. If the score is not there, then PHQ-9 needs to be done. So that's what's one way that we did to engage our providers. And then we realized, so we were doing okay, not too bad. We tried to, we said how we are gonna make it more automatic. So we have a place in Epic where the best practice alert is there. So we make sure that MCIT created a best practice alert for our patient. The problem is that all patients receive this best practice alert, not just the diabetes one. I'm going to explain to you why the problem was that. So since the best practice alert was receiving by everyone, so nobody was paying attention anymore. That was the issue. So we had to continue educating our MAs. We realized, okay, what are we going to do more? We created basically a poster, something that we are attaching in the intake room to make sure, please assess for depression screening, educate our provider again, and make sure that we are retrieving the data appropriately. So at the end of the study, we have to see that all these PDSS cycle basically did improve significantly the number of patients that were screened. We realized that many of our patients were already basically followed by a mental health provider, were on therapy or on medication. And we were able to look at our patient as a whole and not just from the point of view of their diabetes, and consider that into account of their treatment. And EMR did facilitate basically us reaching this goal, but we have not reached the 75 percentile. And I have to say that the fact that our social worker is at the same place and help us a lot with that, help us progress and get there, and this multiple, as well as multiple PDSA cycle, being on call with type 1 exchange, help a lot to keep us on in line. And so we realized that some of we needed patient already, some of our patients were already managed by a mental health provider patient. Some patients were refusing or unable to complete. We do have, I don't know how much patient do you have that have autism or developmentally delayed. So we realized we have a good number of patients that have these conditions. So those are the ones that are out. And this best practice fire too much. We have to realize, we have to find another way. That's why we develop basically reminder for our ancillary in their room, intake room. And the other thing we realized that this best practice was not going to our nurse educators. So now we are working on that as well to get them, ticket was created for them to receive it as well, to be in the loop. Thank you so much. If any question? Yes. Hi. So, right. So we are lucky enough. We have a social worker in the staff, and I have to say, we fundraise for the social worker every year. We just finished a fundraiser. Thank you, Lori. She's organizing that, and she's just for diabetes, and she's just for a pediatric endocrinology diabetes center. And I usually, when I see that, I just send her a message to Danielle, please reach out to this patient. I told them to take an appointment with you. It could be through, virtual, or it could be in person, but we do follow up with, we have the social worker that follow up with the patient and make sure that they are safe.
Well, to move on, we have another presentation on depression screening, ongoing efforts for improving depression screening at a pediatric diabetes center by Jeniece Ilkowitz at Hassenfeld Children's Hospital. I'm sorry, Miss.
That's okay. I'm actually going to be giving this. I am not Jeniece Ilkowitz. I have to give that disclaimer. I'm Mary Pat Gallagher. And let me see if I can just pull up our slides. So we had presented on our initial work with the T1D exchange, trying to improve our depression screening, as well as other types of behavioral health screening. And let's see if that's right. And just to give you an idea of who we are, there are 5 pediatric endocrinologists who see diabetes patients. We have 2 additional endocrinologists who do not come to our diabetes center. We have a nurse practitioner who also has her CDCES. We also have 3 fellows, 1 nurse who is not a diabetes educator, and then 5 diabetes educators split between dietitians, nurses. We have 1 social worker and a shared psychologist, shared child life specialist, shared child and adolescent psychiatrist, and a neuropsychologist, all of whom I think have been really invaluable in this work. Also family and youth advisors and our research team, who really is also spearheaded our quality improvement work. We have about 700, probably more than that now, as I said earlier, between 700 and 800 youth with all kinds of diabetes, and about 70 new onsets per year, including type 2 and type 1. And we opened in 2016. And so when we began the Pediatric Diabetes Center, I had a really strong interest and belief in the importance of behavioral health. And so we had 1 million screeners right at our fingertips, ready, right? Because we had psychologists and social workers, and I was interested in family conflict and responsibility questionnaires. But when we joined the collaborative, I realized that if we're trying to build a program and we're trying to make sure that it's just not my patients that are doing these screeners or that are discussing these things, that we need to measure whether or not we're actually speaking about it. And so I view the screener as a way of measuring, not necessarily even an accurate measure of their distress or anxiety or depression. As an example, yesterday I saw a young woman who is a senior in high school. She's going to an Ivy League school, committed for a sport. She's the president of her class. She's on a hybrid closed loop pump. She's doing great. And her PHQ-4 was all zeros, 0, 0, 0, 0, 0. And sat down, talked to her for a few minutes, hysterical. And then in a minute, her mother too, hysterical. So now everyone's hysterical, but we had a 0 on the PHQ-4. So having said that, I still think it's useful for 2 reasons. One is it brings into the room the idea that I care about how you feel. And 2, it's okay to be anxious, depressed, distressed. It doesn't mean that there's anything wrong. So it's not as if you get a certain level and I shove you over to the social worker. It's like you failed, right? That I don't want anyone to feel that way. We do have resources available if people want them, but a lot of the distress, it just takes 5 minutes for us to sit there. You know, she just kept saying things that were absolutely right. This sucks. I'm so angry. I'm so tired of this. It's been 10 years already. She didn't need to go see the social worker. She was mad and I didn't blame her, you know, so we just sat there and experienced it together. I know you guys all know this. That's the first 2 of the PHQ-9 and the first 2 of the GAD-7, and then we cascade down. I chose it because I thought both anxiety and depression were important, but as I said, it's really not just limited to that, and I don't take it. I mention it, whether it's positive or negative. Oh, I see you're feeling great. Seems like not too stressed out about school, really normalizing, trying to, right? Even if they don't score in an elevated range. So previously, we talked about administering it with the paper version first, which Siham mentioned also was problematic for them. It was problematic for us. We turned it into a REDCap survey, which they could take on their phone, but then we still had to enter it into the EHR. We turned it into something that could be integrated into the EHR. And we increased our screening completion rates from 2% documented, 2% to 50%. And this is the other reason to really use it is if you can't measure what you're doing, you can't improve, right? And so I would have thought it would have been more than 50%, right? If you had asked me, but measuring, it wasn't. So we said, okay, we're going to increase screening completion rates that are documented in the EHR by 10% over the next 6 months. And so we did a fishbone and PDSA cycles. There are a lot of different issues. Training was needed. You know, some caregivers were taking the survey, even though it says, are you the patient? They were still filling it out for their children. It was one of many questionnaires, and it required buy-in from multiple disciplines. All the doctors, the MAs, the front desk, the diabetes educators, everyone, nursing, everyone was involved in this. When we did this, we needed more tablets, we realized. Resistant, survey fatigue, parent completing, overhearing people. Initially, we only had English, and now we only have English and Spanish, so that's still a barrier. And some kids don't use phones. We have a large religious population that we care for that they don't have smartphones, and giving them an iPad or asking them to fill something out on a phone is not comfortable for them. And we have a shared MA system with other, even though we're separate on the back end, the MAs go back and forth with other specialties. So my PDSA cycles are not as pretty as Siham's, but the first thing we did was we created the BPA for staff that the PHQ-4 was due. And what happened was the patient did it on the iPad in REDCap, and then the nurse looked to see, she got an email that it was done. And then we realized, oh, okay, we were confirming if the BPA fires, and we are confirming that the patient did it, but somehow we didn't have that much of an improvement in our rates. So we checked our electronic health record logic, continued education for the staff, and converted the screen to a MyChart intake form option to move everything to the EHR so we wouldn't have to enter it. So we were so happy and excited that it was on the welcome tablet, PDSA2. Questionnaires were administered at check-in along with other intake questionnaires. And so we thought that would go well, but it didn't go well. The PHQ-4 was very rarely completed. It was not the first questionnaire on the tablet. And the initial tablet questionnaires were for the parent, which contributed to the parent continuing to answer the PHQ-4 for their child. So we said, okay, we're going to separate to a different tablet. That tablet will go to the patient or the child or adolescent, and the other will go to the parent. And front desk staff were alerted and trained only for us to find out that when they scanned the iPad for the child, it didn't pop up that anyone was due for a PHQ-4 because your intake has to be completed. And the intake wasn't 100% completed yet. So nobody was getting PHQ-4s. And we were like, what's going on? So we figured that out. So then we're like, okay, so it can't be at the front desk. So it was too much on the RN. So we switched it to the MAs. So now, okay, I'm supposed to be done. So now the MAs, but this is really the end of what we're doing. Now the MAs are giving the tablet. When they scan the tablet, because the child is already fully checked in, it is working. And you'll see here, we had some dips, right? This is when we said, okay, something's wrong. So things got much worse before they got better. And I think that's really common, right? So after we moved it to the separate tablet, it decreased, but we identified why. And we were back to 79% in August of 2023, and we're still working to improve the process. Sorry, those are just future PDSA. Oh, sorry. Any questions? I'm doing something very bad. Sorry. I'm sorry.
Okay, so we have a next presentation. Okay. So our next presenter is going to be talking on systematically developing and piloting an eating disorder screening process at a large pediatric diabetes center. And this is leased on our program, Rebecca Campbell at Barbara Davis Center.
Okay, as she said, going to talk to you guys about our process for developing and piloting an eating disorder screening process. I'm presenting on behalf of Paige Trojanowski and Holly O'Donnell, who really spearheaded this, but I'm a part of the team that's working on it as well. So to start, people with type 1 diabetes are at a significantly increased risk for eating disorders, which can lead to severe medical complications and compromised diabetes care. Currently, most pediatric diabetes clinics do not screen for disordered eating, only about 30%, and only about 15% of those are using a validated measure. We had 3 goals for this initiative. So 1, describe the process for developing an eating disorder screening protocol. 2, report the preliminary results piloting the protocol. And 3, describe provider response to the screening. We sought to complete a gap analysis. We wanted to select a validated measure, and we wanted to determine a screening process. Beyond that, we also sought to train team members on screening procedures, to create a current state process map in an ideal state, and then to gather feedback from team members. After we initiated our gap analysis, we sought stakeholder input. So we interviewed both providers and patients, and we broke it down into 4 general buckets. So resources, next steps, specifically fear or anxiety around next steps, time constraints, and then barriers related to people, both patient-specific and staff-specific, similar to what other people said. Not knowing what to do or lack of confidence in knowing what to do if a patient screens positively, not having the time to address it in a clinic visit was also a concern. And then a lack of behavioral health personnel to follow up in the event of a positive screen. We currently have only 2 social workers and 1 psychologist for 4,000 patients. So that's a concern too. So our results are as follows. We found our gap analysis, less than 1% of patients had disordered eating documented in their medical record, which we know is likely inaccurate based on the rates of disordered eating, and T1D is closer to about 3.5% for females and 0.5% for males. We selected the Diabetes Eating Problems Survey Revised, otherwise known as the DEPSAR. We determined administration method, and then we developed a screening process. We use REDCap as well. However, it's not currently integrated with Epic, so there is a lot of manual work that goes into it. And then we found that providers reported neutral to positive feedback in regards to the screening process. Our pilot, we surveyed 28 individuals. We found that about 28.6% screened positively, which is in line with the literature that says it's around 30% of the population. So that gave us some confidence in the measure that we were using. And then next steps, I'm a part of a team that's been working with a coach from a QI Improvement Academy to improve our process for this. And then we're hoping to adapt that to our depression screening process as well. And then we're also hoping to move on to Welcome Mobile, wherein it's part of the check-in process and then it's automatically integrated, but that's a work in progress. So stay tuned. Okay. Any questions? Thanks.
Questions? I saw a hand over here.
Of those 28 that flagged positive, did you look at like that those were recognized prior to them screening positive at all, or was this like a brand new finding? You know,
that's a great question. Paige would have more information about that, so I'd be happy to give you her info. I wasn't a part of the initial piloting, but yeah, great question. Sorry, the weights. Yeah. I think, I mean, to my knowledge, just here, nothing out of the ordinary, but again, Paige would have more information about that. Okay.
We have one more question. I see a hand in the back.
Okay. See a lot of increased risk of eating disorders, also on things that quote unquote like diabetes and insulin. And an issue that I think is just like having mental health providers available, especially when that understand diabetes, whether it's that anemia or just carb restricted consumption experience is that up to facility providers like we kind of tackle the issue that we were, there's so many positives. Like what was the next step? Yeah.
Sure. Currently, the process is if the patient screens positively, it will trigger a handout for the provider to give to the patient with resources outside of the Barbara Davis Center. I think maybe moving forward, that will look a little bit differently, but just because of the time and staffing constraints. So there isn't as much, in the visit care that's happening. Do we?
Out of time. Okay. Do we have time for one more question?
Okay.
Really okay. We do. Okay. Perfect.
I think
okay.
So basically, my question is that the people that screen positive, did you look at their A1Cs as well? I may have missed that. No. Sometimes they can be very not only disordered eating, but they be worried the most about the people obviously with the high A1C.
Right. I don't think we looked at that for the purpose of this pilot, but that would be a great idea going forward. Yeah. Thank you
for that great presentation. So our last presenter is Korey Hood at Stanford, and he'll be presenting on DiabetesWise Pro Diabetes Device Digital Platform.
Thanks. Thanks, everybody. This has been such a great session on the psychosocial side, and we're taking a little bit of a right turn into some things I'm going to talk about. I think maybe I was put into this session because I'm a psychologist, so and it's somewhat informed the work that we do, but it's been really robust discussion, and I think that the work that's being done on screening, whether you're talking about the eating, disordered eating, depression, anxiety, it's really great work that's being done. So I applaud everybody who's been working today. So a little bit about DiabetesWise. I want to first acknowledge that none of this is possible without support from the Helmsley Charitable Trust. And so they've been great funders and collaborators on this work. And what we set out to do, and if you look here at the number one, we identified this problem, which was that there was really no free, unbiased, unbranded resource for people to compare and contrast diabetes devices. People would have to open multiple pages and look at different resources. And so both as a person with type 1 diabetes myself, but as somebody who's been embedded in diabetes clinics for 20 years, we know that this is a significant problem. So we explored options. We talked to healthcare providers. We've talked to a number of other individuals, kind of the stakeholders in this. And we decided on a digital and online platform, and we called it DiabetesWise. And so we created content, and within DiabetesWise, there are device features. So there's a library you can search. There's a wisdom component. You're hearing a lot of these, experiences from people as they start tools. And one of the ways that the psychosocial side really is embedded in here is in all of these stories, you hear people's frustrations with the current state that they're experiencing, either if it's in healthcare or it's using a device, it's not being able to access the device that they want. And so we've and what I'm going to spend the rest of the time talking about is really the focus, which has been on helping healthcare providers. So those who are helping people with diabetes really gain some of these tools. And so we created DiabetesWise Pro. And I think one of the other ways that it's kind of that we've been part of this group is we've spent some time over the last year talking about within the QI collaborative, what are some ways that we can get some of these tools from our platform into different clinics and test how they can work. And so I'll show you what I mean with a few of these. So when we thought about the value proposition, so up under the banner up there, it says value proposition. We thought of a few different ones that we think for healthcare providers caring for people with diabetes. One is we think that we can help them match devices to kind of a profile or a persona that you're interacting with. We know that the patients, the people with diabetes, the families that you see, there's not one that's like the other, but there are some that kind of cluster together. So we also wanted to streamline the prescription process. And you heard Dr. Levy, you heard a number of people talk this morning about, I think maybe it was, there was a conversation about 200 plus Medicaid plans and carve-outs that have different prior authorization. It's not an easy prescription process, whether you're talking about a drug or a device. And we were just talking about New York. And then we also thought it was going to be important to help people access insurance data, because this is one of the tools and one of the kind of pain points for providers and for people with diabetes. I keep forgetting that I have this. So I'm going to just tell you about a few different features of DiabetesWise Pro. So this is all free. You can go to our website, and I'll talk with you more about it as the day goes along, and pull me aside and we can talk some more. But there's a device library where people can compare different devices. I mentioned about the wisdom. We have providers on here. We have people with diabetes telling their different stories. You can see here, Dr. Sumaira Ahmed, one of our collaborators. I've yet to find an individual who could not benefit from at least one of the potential diabetes-related technology devices out there. And then, I think one of the features that people gravitate toward is the comparison tool, where you can put two different devices side by side, and you can understand what do people say about it from an active lifestyle standpoint? What do people say about avoiding highs and lows? How's it feel on the body? And so these tools then can be, you can, pick one that you've decided on or you've compared, and you can then do a little bit more work to see if this matches the patient, the person sitting in front of you, whether it can match their experience. And then where we spent a lot of time over the last year is really trying to create a tool that can help streamline the prescription process. And so there are just a few, I don't think I can get rid of it, but there's just a few inputs that are needed whenever you use the prescription tool. You select the device type, you select where you're at, what state you're in, the plan type, whether we're talking about Medicaid, Medicare, or private insurance, and then the payer information. So once you put that in, we've created a system where we pull in insurance data, payer data, and it can tell you what so the output looks like this. It's a summary of the coverage that's going to be based on this information that we have. So for example, if you did this in California, which is where I live and work, it'll spit out that Anthem in California has Dexcom G6 on their formulary. It's distributed by this provider, and all policies require prior auth. When we've talked to a number of different healthcare providers, whether you're in a diabetes specialty clinic, primary care, family practice, pediatric, adult, the big things that they ask first are, is this covered? And then do I need prior auth? And so we can, you can get this information freely and quickly and reliably. And then it starts a longer process of working through how to get the prior authorization and all the extra work. We also provide different information, and it's a little bit blurry here, but if you open it on through the links that were provided by the quality improvement team, you can see the different codes that are potentially going to be needed, whether you're doing a DME or pharmacy benefit. And one thing that you may have noticed is, especially over the last year to 2 years, there's been some movement away from DME for a lot of different devices and technologies, and more so on the pharmacy side. I mean, my thought is that this is a positive move, but others may have different ideas on it. But so we provide both the DME and the pharmacy codes here that you may be interested in. And then you can also link out to the specific certificate of medical necessity documents. We don't populate them for you, but you can access everything that you need here. And the point in all of this is to make it easier to help the person with diabetes access devices and technologies that they want or that they may see as beneficial. And as a healthcare provider, you may also view that as it'll hopefully provide some reduced burden in the work that you're doing. You can also go through if you need more specific information, or if you're working with maybe you have a third party that's doing the billing, or you have it all in-house. You can access all the different documents that come from the payers. And so our partner in this is Policy Reporter, who provides all of the payer data and has contracts with all of the different ones. So in summary, and I didn't really get back to why there's a psychosocial piece, but I'm here and I already presented. So no, but DiabetesWise Pro, we build it to inform and improve the prescription process. We think that this can be a really beneficial tool. As I mentioned, the features include device library, comparison tools, prescription support. And because we're supported by Helmsley, we can, and they have a real interest in making this free, unbiased, unbranded. I mean, we certainly have a bias that these kind of devices and tools and platforms can help people with diabetes and can also help healthcare providers who are working with them be maybe more agile, or can help even more than what they're already doing. But so our bias is really that we want to get more people on, and we've got to do that by increasing access and awareness. So thanks. And the website listings are at the bottom and you can reach out to me too if you have any questions.
Maybe psychosocial or maybe a little bit more ethical. What is kind of your recommendation or the website's recommendation on discussing devices with someone if it's not covered under their health insurance? So like in my state, our Medicaid currently does not cover a particular type of pump with an automated delivery feature. We're advocating for that, but families get educated about everyone and kind of in an unbiased way, and they say, I want that one, but we have to say, okay, you either have to wait, which many do, or do you want to think one with tubing? And many don't. So how do you recommend that?
Yeah, I think that it's a great point. And I think that what we're hoping to do is to generate awareness that there are options. And then what does happen is that then those options get funneled down by the number of different things that are around. It could be comfort level in prescribing. It could be what's covered. But I think that, but generally, I guess, and you asked it kind of from an ethical standpoint, I think that it's part of our job is to make people aware of what's available to them and then to help them walk through the process after that. What I think is what my clinical experience has been is that if somebody has the option to do, if a tube pump versus a non-tube pump, but they want to do a pump, and then they're told that they can't do, a non-tube one, then they're still going to do the other one. And so I think generally people have access to some increase in what their kind of level is, in terms of their comfort with, and while I have, one of the things that we saw, and I didn't talk about this because I wanted to focus on the provider side, was that when we've done some studies, both where we've controlled it more so, as well as what we've reviewed with people with diabetes, when they go to DiabetesWise to learn some of these different things, what we're finding, what we draw people into the platform are those that have fewer diabetes resources, those who are less connected, people who are using meters and injections and looking for something more. So I think it's a really important point to think about kind of the universe of potential tools that people have, and maybe you have to kind of hide some parts of it. But I think that what we're seeing is that there's a real thirst to understand what's available to them. So, and then I think Mary Pat.
Add one thing. Because it is so bizarre the way New York works, and you can go back and forth between different managed care Medicaids and have different coverages. We wind up advising people to switch insurances if they feel that way. That's in New York specifically. I don't know how it works in other states, but they are able to do that with managed care Medicaid pretty easily. People who have employee-based insurance, that's not true. But I feel pretty strongly that we have to show everybody everything that's out there. And, it is unfortunate if they have a plan that doesn't cover it. But I think they need to know what's out there. We don't want to be keeping things from them. That's all.
Thanks. Other questions? Don't know if...
Thank you to our 5 presenters for excellent session. I think we're actually right on time. And so any last questions? Oh, sorry. Was there any virtual questions? I want to make sure if anyone's listening. No. Okay, perfect. Okay. Oh, one last, and then I think lunch is next.
Great. Sorry, I'm the last question between you and lunch. I had a general question from some of the previous presentations about implementing like changes within the EMR and best practice alerts, and just the overall timeline from, for example, when you initiated that within your clinic to when it was actually implemented. Because anecdotally, and also I'm a representative from the Helmsley Charitable Trust. So I often, we hear a lot of anecdotes from clinics, and, understanding kind of what it takes to actually, get something from idea into practice, especially from an IT standpoint, is something we hear there are a lot of roadblocks with. So I would be interested.
So I think that Siham had to leave. So I think I'm the only person who spoke to that today. And I think that underscores how important the Helmsley financial support is. You really need dedicated people within Epic and IT, which I learned through this process are not the same. So there are, and then there's another group of people who are my chart people. So having to get all those people together, we had a really great experience. But even with that, 4 to 6 months to do that. Yeah.
I mean, on institutional priority and how that fits in with the institution. We're trying to make some revisions, but it's been up to maybe 2 years, but that's kind of like asking and then kind of following up later on. But it's already on something that's built. We just want to revise it to make it even better for some of the screening. But okay. Well, excellent. Well, thank you everyone for joining. And I believe lunch is it where we had breakfast this morning? Back out in the hallway. So great.